Assalamualaikum doctors. In this video, I am discussing supraventricular tachycardia history management portions. So first, investigation. What investigation we do? Full blood count, that is peripheral and peripheral blood film and blood culture. Then inflammatory markers ESR, CRP and ferritin, cardiac enzyme, myoglobin, troponin T and I, CKMB, BNP and LDH. So troponin T and troponin I, D dimer, urean electrolyte, creatinine, liver enzyme, ionized calcium, viral PCR and viral antibodies to exclude myocarditis, blood gas ABG, 12-beat ECG with rhythm strip. During supraventricular tachycardia, what we find, regular narrow complex tachycardia, rate is 240 plus minus 40 beat per minute. PUAB usually invisible. So rarely regular broad complex tachycardia. Okay. So mainly narrow complex tachycardia, heart rate is 200 to 240 beats per minute. When in sinus rhythm, Wolff-Parkinson-White rhythm. The Wolff-Parkinson-White, that is pre-excitation with the short PR interval for age and delta wave in the 10 to 20% of children can be normal. Imagine chest X-ray to exclude the differentials and echo to assess the structural anatomy and the cardiac functions. So again, the investigation I am telling, first of all, full blood count, peripheral blood film and the blood culture. Inflammatory markers are ESR, CRP and ferritin. Cardiac enzymes are myoglobin, troponin T and I, CKMB, BNP and LDH, D dimer, urea and electrolyte, creatinine, liver enzymes and ionized calcium, viral PCR and viral antibodies to exclude the myocarditis, blood gas. 12-lead ECG with rhythm strip, that is during supraventricular tachycardia, ECG finding is regular narrow complex tachycardia, rated 240 plus minus 40 beats per minute and disease. And the imaging we do the chest X-ray and the echo. Echo we assess the structural anatomy and the cardiac function. Now management plan of the supraventricular tachycardia. First of all, resuscitate. Fast ABC approach. If shock though, so resuscitate. Continuous cardiac monitoring with the ECG recording with the each intervention. Vagal maneuver. Safe method only. Should be explained and educated the parents. So resuscitations, ABC approach, then continuous cardiac monitoring and vagal maneuver. Diving reflex in neonate and infant. Diving reflex is that use of ice bag over the forehead and nasal breath for 30 seconds or wrapping in infant in a towel and immersing face in ice water for 5 seconds. So diving reflex, that is neonate and infant, that is using of the ice bag over the forehead and nasal breath for 30 seconds or wrapping the infant in a towel and immersing the face in ice water for 5 seconds. Then Valsalva maneuver, older children. Valsalva maneuver is that ask the children to blow into a 50 ml syringe for a 15 seconds whilst lying down. Ask the child to handstand for 30 seconds, hold his leg for safety. Okay. So Valsalva maneuver for older children, the procedure is that ask the child to blow into a 50 ml syringe for 15 seconds whilst lying down. Ask the child to handstand for 30 seconds, hold the legs for safety. In younger children, less than 30 kg, gently hold the child upside down, then back to supine. Okay. Adenosine IV we give, synchronous DC shock, general anesthetic must be given if responsive to pain, subsequent management. So adenosine IV, synchronous DC shock and subsequent management. Admit to the high dependent unit, HDU, continuous cardiac monitoring, blood test to check for electrolyte abnormalities, urea and electrolyte calcium and magnesium level. So urea and electrolyte calcium and magnesium level. Discuss with the specialist pediatric cardiology center. All patients will require pediatric cardiology follow-up, local or tertiary. So management, I am telling with a table, that is first of all ACs, shock present or not. If shock not present, then vagal maneuver. Vagal maneuver we know that. How can we do? By in unit diving reflex, Valsalva maneuver for older children. Now about the if shock present, then first vagal maneuver, if not delay. Then yes, establishing IV access quicker than obtaining defibrillator. So IV access we are doing. Then we give the first we give adenosine 100 microgram per kg. After 2 minutes, adenosine 200 microgram per kg. After 2 minutes, adenosine 300 microgram per kg. Consider adenosine 400 to 500 microgram per kg, neonate 300 microgram per kg, maximum 12 milligram, and 12 microgram. Synchronous DC shock, amiodarone, and other anti-inflammatory seek advice. So first we are trying with adenosine after IV access 100, then after 2 minutes 200, then 300. Okay, 100, 200, 300. Then we are going the synchronous DC shock, that is 1 joule per kg. Then not working synchronous DC shock 2 joule per kg. Then consider amiodarone. Do not use verapamil or amiodarone in the same patient. As patient have negative inotropic effect, do not use verapamil in children aged less than 1 year. So verapamil we are not using. First we are giving what is ABC approach Valsalva maneuver. Then IV access. After IV access we are giving adenosine 100 microgram per kg. Then adenosine 200 microgram per kg. Then adenosine 300 microgram kg after 2 minutes. Then we are going the synchronous DC shock 1 joule per kg. Then synchronous DC shock 2 joule per kg. Then going for the amiodarone. So this is the treatment of supraventricular tachycardia patient. Thank you.